Well, good evening, good afternoon, or good morning for anyone who's tuning in globally. I'm Dr. Georges Benjamin, the Executive Director of the American Public Health Association. Welcome to the 22nd webinar in the COVID-19 Conversation series entitled The Third Year of COVID-19, Is This the New Normal? It's brought to you by APHA and the National Academy of Medicine. Now, today's webinar has been approved for 1.5 continuing education credits for CHESS, CME, CNE, and CPH. And please note the speakers have disclosed conflicts of interest. If you want continuing education credit, you should have registered with your first and last name. Now, everyone who wants credit must have their own registration and watch today's event in its entirety. All of the participants today will receive an email within a few days from cpd@confex.com with information on claiming credits. All online evaluations must be submitted by October 4th to receive continuing education credit. Now, the COVID-19 Conversation series has been on break for a few months, but with the rise in Omicron and the conversation about what we can expect in coming months, we thought now would be a good time to come back and have that conversation. If you have any questions or topics you'd like us to address today or on future webinars, please enter them in the Q&A box or email us at apha@apha.org. That's for questions, apha or apha.org. Now, if you experience technical difficulties during the webinar, please enter your questions in the Q&A, and please pay attention to the chat for announcements about how to troubleshoot. So questions in the Q&A, and pay attention to the chat for announcements about how to troubleshoot. Now, this webinar was being recorded, and the recording and transcript will be available on the COVID19conversation.org site in a couple days. More information on this series and recordings of past webinars are also available at this link. Now, as you know, we're all really kind of all zoned out on COVID, and we're all trying to figure out where we go next. So with that, I want to introduce our moderator today, Dr. Megan Rainey. Dr. Rainey is a practicing emergency physician, researcher, and national advocate for innovative approaches to public health. She holds the Warren Alfred Endowed Professor of Emergency Medicine at the Albert Medical School of Brown University, and is the academic dean of the School of Public Health at Brown University, as well as the founding director of the Brown Lifespan Center for Digital Health. She has obviously served multiple national leadership roles, including co-founder of the GetUsPPE.org, which is a startup nonprofit that delivered donated personal protective equipment for those who needed it most. She's a fellow of the 5th class of the Aspen Institute Health Innovators Fellowship Program and a member of the Aspen Global Leadership Network. Lots of awards for technology innovation, public health, and research, including Rhode Island Women of the Year and the American College of Emergency Physicians Policy Pioneer Award. She's also a frequent media commentator on outlets ranging from the BBC to CNN to the New York Times. She's got a bachelor's degree in history of science, graduating summa cum laude from Harvard University, her medical doctorate, graduating Alpha Omega Alpha from Columbia University, and her master's in public health from Brown University. She completed her residency in emergency medicine and a fellowship in the Injury Prevention Center at Brown University, and she was previously a Peace Corps volunteer. Megan, it's all yours.
Thank you, Dr. Benjamin. It is an honor and a privilege to be moderating this webinar today with you, as well as with so many colleagues who I've known and admired for many years. Now, I think it's safe to say that we are all tired of COVID-19, and a year ago, even 4 months ago, we would have had trouble imagining that we would be where we are today. It's yet another international surge, yet another variant. So in this webinar, we're going to hear from much admired experts from across the country about the current state of the pandemic, with a focus on preparing for new variants that may yet be coming, the role of vaccines and therapeutics moving forward, and how to shape our public health guidance as we move into this next phase. We will address not only those issues, but also talk about where we're going next and how all of you can help integrate the ever-changing guidance and science into your own work in your own communities. I will remind you all to please use the Q&A feature to ask questions as they arise. I will be keeping track of them and will ask them towards the end of the presentation. I thank you in advance for your engagement and your questions. And with that, I'm going to introduce our panelists, and then I'll turn it over to each of them in turn to give a brief presentation, again, followed by a Q&A. So I'm going to start with Dr. Nuzo. Dr. Jennifer Nuzo is a senior scholar at the Johns Hopkins Center for Health Security, an associate professor in the Department of Environmental Health and Engineering and the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health, and a senior fellow for global health at the Council on Foreign Relations. An epidemiologist by training, her work focuses on global health security, with a focus on pandemic preparedness, outbreak detection and response, health systems as they relate to global health security, biosurveillance, and infectious disease diagnostics. She directs the Outbreak Observatory, which conducts, in partnership with frontline public health practitioners like many of you, operational research to improve outbreak preparedness and response. She's also the lead epidemiologist for the Johns Hopkins COVID-19 Testing Insights Initiative, housed within the Johns Hopkins Coronavirus Resource Center. And she will also be moving up here to Brown in just a couple of months to run our Center for Pandemic Preparedness and Response. So I'm excited not just to welcome her to speak on variants, but also as a future colleague. She's going to be talking about what we've learned from Omicron, what's happening now, what's coming next, and how do we prepare. The next speaker will be Dr. Larry Corey, an internationally renowned expert in virology, immunology, and vaccine development, and the former president and director of Fred Hutch. His research focuses on herpes viruses, HIV, the novel coronavirus, and other viral infections, including those associated with cancer. Dr. Corey is the PI, or principal investigator, of the Fred Hutch-based operations center of the COVID-19 Prevention Network, or CoVPN, and co-leads the network's vaccine testing pipeline. No one better than him to speak to us about vaccines, the state of what we know about vaccine efficacy, and how the strategy will change going forwards. And I'll stop with my intros actually and let Dr. Nuzo speak, then have Dr. Corey speak, and then I'll introduce our last two speakers after that. So Dr. Nuzo, take it away.
Thank you so much. Sorry, I couldn't get off mute for a second. Appreciate the warm introduction, and also appreciate the opportunity to speak at this session. I, like many others, didn't expect us to be having to talk about COVID in the way that we are right now at this point, but nonetheless, here we are. And what I'm going to do today is just talk about where we are in the general sense, and talk about variants in the general sense, to focus really on what the impact has been rather than the variants themselves. So if you could advance to the next slide, I'm going to start first by talking about the situation in the United States. And as Megan mentioned, I'm on the team that is behind the Johns Hopkins Coronavirus Resource Center. And what I'm showing you here are data from today showing the case situation in the United States. So we have to date reported over 72 million cases, and continue to be one of the countries that has been hardest hit by this virus in terms of the number of cases being reported. But I want to call your attention to the upper right-hand side of the graphic that I'm showing you, where you see these sort of red bars. And that is basically the 7-day average of cases that are reported. And as you can see, we basically are in a skyscraper. The cases, around the holidays began shooting straight up, and everybody knows this. You've heard the news stories, you've felt it, you've seen it. You probably know lots of people who have gotten the virus, and that is absolutely reflected in the numbers that we're seeing. So this is a situation that, truthfully, I did expect that we would have an uptick in cases around the holidays, based on the fact that we had an uptick at the end of the summer, but I don't think anybody ever expected to see case numbers quite this staggeringly high. And if you go to the next slide, there's clearly been a reason for that, and that is this new variant, Omicron, that we've been hearing so much about for the last month. It is now the dominant virus circulating in the United States, and is the dominant virus circulating in many countries. And it has come with it a number of really important features. The key being, probably the most important feature being, its incredibly high transmissibility. Where we are seeing people spreading the virus and spreading the virus more quickly and spreading the virus to more people than we had seen. So the case growth has been really quite explosive over a relatively short period of time. Now, you've also heard in the headlines some evidence that on a per case basis, it may be less severe, meaning fewer people who get it are going to the hospital. And for those who are going to the hospital, perhaps they aren't requiring the level of intervention than they may have with earlier forms of the virus. But I have to stress that those attributes, while welcome to some extent, don't completely make up for the fact that this virus is so incredibly transmissible. And what we're basically looking at here has been a flash flood. And so when the flood waters come very quickly over a short period of time, that comes with it, brings with it its own challenges, and it's very, very hard to absorb. So that is what we've been living through for the last month or so. But if you go to the next slide, the situation is beginning to turn a bit, where we are now, fortunately, starting to see finally a decrease in the cases being reported in many states. So what I'm showing here is a graphic, and this again is pulling fairly recent data, showing the growth in cases recently, and the weekly change in cases. So I generally like this graphic to have a lot of green, and the darker the green, the better. Reds are not great to see, and a couple of weeks ago, there were a lot more reds on this graphic. So it's good news that we have less red, but as you can see, we still have red. So we're seeing still a growth in cases in several states. So not all states are seeing the declines that you may have been hearing about on the East Coast, for instance. So we, in fact, 19 states this week are reporting case increases, but the rate of change in most of these states is slowing. So that is certainly welcome news, and we'd like to see this trend continue. Now, you may have heard that Omicron has in other countries sort of come and gone, perhaps in a period of, a couple of months, or not gone, it's not gone, but the cases numbers will start to decrease once they start to decrease, they decrease rapidly. I think it's going to play out differently in the United States, in part because we're such a geographically diverse country, and in part because we've seen over and over again this virus spreads in social clusters, and not all social clusters mix with each other. So I think we're going to continue to see spread and possibly not as rapid declines as other countries have reported. So this next slide is showing the hospitalization, and hospitalization is a lagging indicator in the sense that we see the trends turn a bit delayed from the trends that we see in the case numbers. So fortunately, we are now starting to see the hospitalization numbers, which are staggeringly high. As you can see, I like showing the kind of time series here because it shows the hospitalizations that have occurred due to this flash flood have eclipsed what we have seen prior, in earlier stages of the pandemic. So that is in part due to the very, very transmissive nature of this variant that we're dealing with. Fortunately, as a nation, the hospitalizations are starting to come down. But again, we are a very big nation, and that is not true in all places. And so there are places where their hospitalizations are, still very much climbing. And certainly in the western part of the country, there are still deep worries there that the trends are not yet in the direction that they need to be. Similarly, we are seeing some those concerns with the death data. They lag hospitalizations. So while the case numbers and hospitalizations nationally may be coming down, the death numbers are still climbing because we are seeing the results of the cases that occurred weeks and weeks ago. Next slide, please. So one of the big concerns that I have about the situation that we're in is very much the case that testing is highly constrained, and perhaps the most constrained it's been at any point in this pandemic. And one of the metrics that I spend a lot of time looking at is test positivity, because it's, I think, probably one of the better metrics we have to gauge the operational situation that we're in. And when I see a test positivity number that's high, and in this case over 25% for the nation, what that tells me is that the answer to the question, are we testing enough, is, a resounding no. Unfortunately, the answer to that question, are we testing enough, has been no for most of the pandemic, but certainly, we like to see test positivity much lower, than 5%, and 25% is just far too high. And so what that means is that we are missing more and more infections that are occurring. They're not turning up in our surveillance numbers because people aren't getting tested. Maybe they're testing themselves at home, but that's not being captured by our surveillance. And we're possibly, turning our telescope to a different part of the sky and seeing cases in a different population than we were when we had more widespread or more available testing. So that is a real worry. And I think it really starts to occlude our vision in terms of, where we're going in this pandemic. And it, certainly deprives us of opportunities to interrupt transmission, to connect people to potentially life-saving care, and to otherwise just improve outcomes. So this is something that I think is going to be the dominant issue in the coming months, is trying to figure out how we expand testing in a way that's accessible to everybody who needs it. Next slide. And because we started talking about variants, I have to absolutely stress the fact that, what we know about variants and where they are occurring in the world and where they're coming from and how frequently they occur is a completely capacity dependent exercise. It's all about how much sequencing is being done and it's being done by whom. Unfortunately, as you can see from this graphic, there is a real range in terms of what percentage of cases are being sequenced by countries out there. And it's really interesting because this graphic plots it as a function of the country's income. And as you can see, it's not purely an income dependent exercise. There are many low-income countries that are doing more than their fair share of sequencing. The blue dot, if you can see it, the dark blue dot is the United States. And about half a year ago, the blue dot was much more lower on the curve. But in recent months, we've really started to catch up in terms of the amount of sequencing we're doing, but we're still not the leader in terms of sequencing. So keep that in mind when you hear about a new variant. One of the questions you have to ask is this all we know? And usually the answer is probably not. There's probably a lot more going on out there with respect to variants that we just don't know because we are so far behind in our surveillance in terms of looking for them. Next slide. So I just want to sort of end on the global picture because, you can't talk about what's happening in the United States without rooting it in a larger context, which is, and particularly when we're talking about variants. And so we have to also look at what's happening. And the Omicron trends that I described today are very much playing out in other countries. If you again look at the upper right-hand corner, you will see those 7-day averages. And again, we are in another skyscraper. These are the global case numbers. I mean, they're just hideously large. And when you see that skyscraper, you understand why that is. And when people ask me about the variants, I have to pivot to the global picture because this is the context that we find ourselves in. If we want to stop fretting about, every other Greek letter that there is to come in the alphabet, the way that we do that is that we have to bring these case numbers down. And the way that we bring these case numbers down and limit opportunities for variants to arise and spread is by allowing more countries greater access to vaccines. So if you go to the next slide. You can see that we're still in a situation where there is intense spread in much of the world. Many countries are seeing intense spread, and there is a high degree of variability in terms of how much access countries have had to vaccines. Yesterday, a reporter asked me, basically, simple question: how is the case that vaccination reduces the likelihood of variants emerging? And to understand that, you just have it's basic sort of math, which is that the more copies of the virus that there are on the planet, the more the virus has to copy itself, the more opportunities there are for mistakes to be made in the copying process. And that is what contributes to the rise of variants, genetic mutations that occur in that copying process. And so if we're able to vaccinate more people to reduce transmission, to reduce the amount of virus, we know that vaccines may not prevent infection, but they certainly may reduce the amount of time that people carry it. We reduce opportunities for the virus to mutate and spawn new Greek letters that we then have to worry about. So I'll end on that note and looking forward to the question and answer session later. Thanks so much.
Thank you so much, Dr. Nuzo. Now I will turn it over to Dr. Corey, who, as I mentioned before, is the former president and director of Fred Hutch, as well as the principal investigator of the COVID-19 Prevention Network. He's going to speak on vaccines, vaccine efficacy, and how our strategy is going to change going forwards. For those who are just joining us, there is a Q&A. Please put your questions in the chat. We'll be monitoring them. And after all of our speakers have spoken, we'll have a time for question and answer with all of our speakers. Dr. Corey, to you.
Oh, thank you, Dr. Rainey. As I think everybody has said, I just want to, there is some, issues with discontent at the moment. We're at month 24. Just to remind that we really have developed highly effective biomedical interventions, the COVID-19 with unprecedented scientific success. We have highly effective vaccines. We have highly effective monoclonal antibodies, both for outpatient therapy and longer-term prevention, and Tripp's going to talk about that, and increasingly effective outpatient antiviral therapy to prevent hospitalization with the protease inhibitors, IV and remdesivir and oral molnupiravir. Next slide. Yet the Delta wave has become the Omicron tsunami of cases that we just heard. There's public fatigue. Can we go back a slide? I got it. COVID-19 lifestyle restrictions are still operant for most of us, and it's clear the virus is firmly established in the human population. New variants, as we've heard, are likely to emerge, and even the less lethal variants, such as Omicron, does produce significant morbidity and significant mortality. Because we have a delay here. Next slide. So the issue is, has science not led us out of this wilderness as well as we need, and are our tools not good enough? Or is it clear that the virus really is quite skilled at antigenic variation, altering itself and spreading quicker than any other human pathogen we've encountered, and that we must continue to build and sustain an implementation science, a basic science, and a translational research infrastructure that matches these viral alterations and continue to improve our countermeasures, which are still subsequently quite okay. So let me just review this. I apologize for what appears to be quite a delay between wanting the slides to shift and not. Susan, maybe you can take back control, because I'm trying to. So my role is to give a quick review of the vaccine program, what has been the anticipated variant change, how has affected vaccine efficacy and strategy, and a little bit about what's next. Next slide. Just to remind us, from discovery to actually getting into people's arms for COVID-19 vaccines was a remarkable 11 months. The virus was first isolated on January 7th. The sequence posted the 10th. The actually spike protein sequences sent from Barney Graham's lab to Moderna as well as to Pfizer was, within a week of that. Within 66 days, RNA was bottled and put it into a phase 1 trial into humans. When Tony Fauci called me on March 3rd to start getting us ready for designing a phase 3 program and mobilizing the academic and clinical research community to test these vaccines, we started working on that and really had that plan by April. These phase 3 trials started in July, one a month in July, August, September, October, but the first ones with RNA in July. We actually had the interim efficacy data on November 9th. For Pfizer and November 16th for Moderna, and the EUA for Pfizer and the EUA of Moderna in the mid-December. So 11 months from beginning to end. Next slide. Now, some of it is, the efficacy was remarkable. 94% against symptomatic disease and essentially 100% against severe disease, against the ancestral strain when the vaccine matched exactly the circulating strain for the RNA. For our first international trial, which was with the 1-dose J&J vaccine, which was done in the United States, South Africa, and much of South America, efficacy was a little bit less, 72% overall. But again, for hospitalization and death was in the high 80s. Next slide. These vaccines were felt to be the breakthrough of the year. We actually were sort of looking good. Next slide, feeling really quite good about the whole thing. And the issues of sort of, just to review a little bit, because the question is how did you do this? And were there any corners cut? Was sort of by the following. We took an approach that was really pretty novel, which was to do large, next slide, single, individualized, random, placebo-controlled, randomized controlled trials for each vaccine, recognizing that the manufacturing time for each vaccine would be different. And that turned out to be the case. RNA came off first, the viral vector second, and then the proteins are third. And they're hard to make. They maybe are the cheapest vaccine to be utilized from a cost per unit, cost of goods. But it does take longer to do this. And even one of the proteins currently is still in clinical trials. We used we took essentially the academic centers of our entire country, participated in clinical trial sites, supplemented with the clinical research organizations from the pharmaceutical companies. We averaged around 90 clinical trial sites per study. The studies were harmonized, so they really all did have essentially the same endpoint. We did that through discussion groups, getting everybody to be bought on with that. We used a common platform and a common laboratories to do both the COVID-19 detection as well as the antibody assays. We had consulting biostatisticians who were with the HIV vaccine program that really designed the studies and analyzed the studies and are doing the correlates of protection. And there was a common DSMB that monitored all the studies that the US government funded and made the decisions about when the trial was ready to mature commonly. So it was an even playing field. Next slide. We also were able to involve the citizens of the country in a very unique way. As I said, we were doing one 30,000 person trial a month for a 5-month period of time. And we needed to enroll the citizens, and we needed to enroll the communities in which the force of infection was the greatest, which meant our Black and Latinx population, and to get them to find out, enrolled at the rate that we could tell that the vaccine would work in these communities. And we were able to do that, frankly, by a marketing campaign that was led by this lady, Sally Bach, at the HIV Vaccine Trial Center here in Seattle. Next slide. We were able, if you could click at the bottom to get this going.
This pandemic is not red.
We're able to do a marketing
campaign.
campaign
Is not blue.
on television and social media.
Black, is brown, is white. It hits all colors and creeds. But even when things look bleak, we know that someone is full of hope and strength and wants to take action. Someone that would take a step forward just to hug their grandkids sooner. Someone that will inspire others by talking the talk and walking the walk. Someone that will roll up their sleeves, because that's what they always do. Someone like you, who wants things to go back to normal and is not waiting for others to act. Someone like you, a mother, a teacher, a nurse, a farmer, a worker. Volunteer for COVID vaccine studies to find a safe and effective vaccine that works for all of us. Help end the uncertainty. PreventCovid.org.
We set up a natural registry for people seeing these kinds of ads to enroll that by your risk factors. Next slide, could be sent to the clinical trial site. So let's go beyond that one. And we were able to enroll these trials, each one within a 6 to 8 week period of time. So we were really conducting trials in which essentially 2,000 people, between 1,500 and 2,000 people a day were enrolled in these trials. And that's really the issues of the seamlessness of how this was achieved. Now, the success was really not quick. I mean, if you look at it, we were able to do this as a sort of scientific establishment because we had put in 20 years of hard scientific effort in what I would say is 4 areas. And it was like just in time sort of putting together an auto part or a car. 20 years of working on mRNA. First, 1992 was when it first showed it translated into a mouse. The patent showing that you could get high transcription by Drew Weissman and Karen Carrico was in 2005. That's the patent that both Moderna and Pfizer have. And much of that was done through funding through Drew through the HIV program, which HIV has really been sort of the, I would basically say the NASA of vaccine development here. 20 years of structural biology that Barney Graham had been working on, first RSV, then the human coronaviruses, and then SARS and MERS, with respect to showing that the prefusion portion of the viral spike protein, or the viral trimer for landing, was the one that was the most immunogenic for neutralizing antibodies. And that if you stabilized it in a particular way with some prolines, you could make a stable prefusion protein. And this has been used in 4 out of the 5 vaccines that we tested with very high neutralizing antibodies. There was 20 years of pandemic preparedness in which the RNA platforms, the Ad26 platforms, the DNA platforms, as well as some of the nanoparticle platforms have been worked on by the Vaccine Research Center, as well as within the HIV program. And there's 20 years in building the research organizations that conducted this, the HIV Vaccine Network and the Prevention Network. By that time, we had 72 clinical trial sites already. We had a large computational and biostatistical group, and we also had laboratories that had validated the neutralizing antibody assays and the binding antibody assays that we actually had just validated in some monoclonal antibody studies. So it was putting these together that led to this rapid success. Next slide. Now, a lot of this has changed, and that the virus has fought back with rapid antigenic variation, the Delta wave and now the Omicron wave. Next slide. And this slide's actually already been shown by Jennifer, that Omicron is now essentially 99.9% of the isolates in the United States, and most of them globally. Next slide. And what the virus has done is changed through selective pressure, and each of the variants has had a decrease in neutralization to neutralizing antibodies induced by the vaccination. They're listed here. Alpha, 2-fold, no real change in vaccine efficacy. Beta, which was first discovered in sub-Saharan Africa, was 8 and 9-fold, didn't really create much of an epidemic or outbreak in the United States. Gamma, 3.5-fold, Delta, 4-fold, and Omicron has upped the ante to essentially a 30-fold decrease in neutralization or resistance to neutralization by the variant. Next slide. And this has affected our vaccine efficacy. This just came out 2 days ago. It looks at the ER visits and the hospitalization visits in a large network of hospitals in the United States with the RNA vaccines. Against Delta, when it came to ER visits, it's 86%. Within the first 6 months after vaccination, drops to 76%, goes up to 94% with your third boost. That works very effectively still for Omicron, 82%. When it comes to hospitalization, the third boost is 94% against Delta. It goes up to 90% with Omicron. These are large databases. The number of cases with Delta are like 250,000. Omicron at the moment is around the 20 or 30,000. The Omicron period is still short. We will obviously have probably some waning immunity. But as far as vaccination goes, we really do have quite good protection still with boosting with both ER visits and hospitalization. Next slide. So we'll sweat through Omicron until we make more monoclonal antibodies and the protease drugs into the field. It is true that we've had dropout of both the Regeneron and Lilly monoclonal antibodies. I think Tripp will say more about those things. Vir's antibody, as well as the Pfizer drug, really come up in the end of April, and for breakthrough cases and for unvaccinated people, that should help. I think better treatment options will alter our perception of risk. In the vaccine area, we do have a durability issue, and how to solve it is where we're working on at the moment. Will a variant increase the immune response and give us better durability? It's sort of remarkable that with the very huge variation we see in Omicron, that still ancestral strain gives us really good cross-reacting antibodies, puts into memory a greater breadth than we have seen. And there are second generation vaccines in development. We're creating a research infrastructure to evaluate which ones add major benefit over current platforms are needed. And we may need to switch platforms to get greater durability. This is where the field is, and this is where active clinical investigation is. Next slide. So the endemicity of SARS-CoV-2 does require a sustained and thoughtful research network. The structure we worked under had a terrific alignment between big pharma and public health. We need a little bit more innovation. We need to let the small guy in now. We need a sustained research program for the continued development of better vaccines and therapies. Jennifer did talk about our global responsibility that we need to vaccinate the world. A lot of these major mutational variants do come from immunocompromised people. On the globe, the highest number of immunocompromised people are in the HIV community, and merging HIV and COVID-19 policies and treatment practices need to be done. We need to spend more time on our policies and programs of getting low and middle income countries the ability not only to have their own vaccines, to have vaccines be part of both their culture and economy, to overcome vaccine hesitancy that is occurring in their countries also. So I'll end with that. I think that's my last slide. To thank the people that we worked with in the countermeasures activity group, as well as Operation Warp Speed. Kathy Nuzo, my co-chair with this, Mike Cohn, John Muscola, Barney, and David Montefiore, and the people illustrated here who worked tirelessly in this vaccine effort. Thank you.
Thank you, Dr. Corey. What an extraordinary quick journey through the development and continued impressive efficacy of the vaccines. And I'm going to use that phrase, the winter of our discontent, a fair amount going forwards. Thank you for that. It is my pleasure to now introduce Dr. Tripp Gulick. Dr. Gulick is the Rochelle Belfer Professor in Medicine and Chief of the Division of Infectious Diseases at Weill Cornell Medicine, as well as an attending physician at New York Presbyterian Hospital in New York City. Dr. Gulick's research interests include designing, conducting, and analyzing clinical trials to refine antiretroviral therapy strategies for HIV treatment and prevention, and assess antiretroviral agents with new mechanisms of action. He serves as co-chair of the NIH COVID-19 Treatment Guidelines panel, is a member of the American Society of Clinical Investigation, the Association of American Physicians, the International AIDS Society, and the Infectious Disease Society of America. He's presented at national and international meetings and published widely. Thrilled to have Dr. Gulick joining us today to speak about how new therapeutics are currently changing the game and will continue to do so in our treatment of COVID, and to talk about the challenges of ensuring broad and equitable access. Dr. Gulick, to you. Oh, and you are muted because it's 2022, so.
and I knew that. Thank you for that kind introduction. I have no disclosures. I'm pleased to be here with you today to really review where we are with COVID-19 treatment in 2022. So let's start by reviewing the clinical course of COVID-19, which is illustrated on the slide here. Over on the left, someone gets infected at the beginning of the illness and may not develop any symptoms at all, may be asymptomatic and may recover from the illness. However, some will go on to progress to develop symptoms over 2 to 7 days. And at that time, the amount of virus in the system, particularly the nose and throat, will increase to very high levels, reaching perhaps its highest levels a day or two prior to the development of symptoms. Again, after the development of symptoms, which, as you know, can be very much like a common cold with cough, sore throat, congestion, many people will recover. However, some will go on to progress. The virus that causes COVID-19, SARS-CoV-2, can be a potent stimulator of an inflammatory response, so stimulating inflammation. Initially, this starts off in the lungs and can lead to severe COVID disease that requires a visit to a healthcare worker, and perhaps admission to the hospital if oxygen is required. Again, many people will recover, but some will continue to progress, develop increasing amounts of inflammation in the lungs, and develop respiratory distress, which may require high flow, nasal cannula oxygen, or even needing to be on a respirator. This may, again, progress over the course of weeks. Some will recover, some will go on to die. And that is a consequence, as we know, of the most severe complications, not just of the lungs, but total body of COVID-19. So how can we impact the course of this illness? What treatment strategies have been employed? Well, two broad categories. One are antivirals. This, of course, is an illness, COVID-19, caused by a virus, SARS-CoV-2. And so coming in with compounds that could interfere with the virus, antivirals, was a strategy thought about very early in the course of this epidemic. Later on, as the inflammatory cascade gets induced, one could use a category of drugs called immunomodulators. These are drugs that dampen down inflammation and the immune response. Now, remember when COVID-19 arrived at the end of 2019 and in the US at the beginning of 2020, we had no effective therapies for COVID-19. We've now come quite a ways. So two arms of the COVID-19 treatment strategy, one antivirals, one immunomodulators. Antivirals take advantage of the fact that SARS-CoV-2, the virus that causes COVID-19, binds to a cell, and in most cases, this would be a cell in the upper respiratory tract first, early in infection, and then goes through a series of processes where the virus essentially takes over the machinery of the infected cell and uses it to make copies of itself. So it makes copies of its genetic material in the form of RNA, and it makes viral proteins, which are processed, and then these all assemble at the surface of the cell and then bud off into new viral particles. Many of these viral particles are fully capable of infecting the next cell that they come into contact with. So we call these sequence of events the viral life cycle. It's how the virus reproduces in the body. How do antivirals work? Well, they throw up roadblocks in this life cycle. The ones that act earliest are antibodies, as Dr. Corey has mentioned. These actually bind to the virus and prevent it from binding to the cell. Another group of agents are called polymerase inhibitors. These are drugs that interfere with the virus making copies of its own genetic material, RNA, inside the cell. And a third group of drugs are called protease inhibitors. They interfere with the virus making its own proteins and then combining them into new viral particles. We now have examples of all three of these that are in clinical use. Again, further along in the course of COVID-19, we see a tornado of inflammation, and substances called chemokines recruit cells and inflammatory proteins first into the lungs and then through many organs in the body. We call this the COVID-19 inflammation storm, and it can lead to respiratory failure and severe complications and death. We do have a whole host of compounds now that can modulate this response or dampen it down, and we call these immunomodulators. So where are we in terms of treatment availability in 2022? For inpatients with COVID-19, we have an antiviral drug known as remdesivir. It is the first and only FDA-approved drug for the treatment of COVID-19. And that harkens back to clinical trials that were completed in 2020 and showed benefit of remdesivir in decreasing clinical progression. And you can see FDA approved remdesivir for the treatment of COVID in October of 2020. We also have 3 of these immunomodulator drugs that have been demonstrated in clinical trials to decrease mortality, decrease death. And these are the corticosteroid, dexamethasone, and 2 other immunomodulators, one known as tocilizumab and one known as baricitinib. And then finally, FDA uses a special program called emergency use authorization when a compound shows promise in the treatment of a disease. And that's been employed widely in the treatment of COVID-19. So the emergency use authorization is not full approval by the FDA, but conditional approval that allows access to promising compounds. And you can see 2 strategies that have received EUAs for inpatients. What about for outpatients with COVID-19? Recently, 3 antivirals have been demonstrated to decrease disease progression in the highest risk patients. Who are the highest risk patients? People who are elderly or have another disease called a comorbidity, such as lung disease, heart disease, or diabetes, or many others, that increase their risk of developing moderate to severe progression of COVID-19. 3 antivirals available. Remdesivir, the same one we use for inpatients, was recently FDA approved just last week for the treatment of outpatients. And then the first 2 oral antivirals, one called molnupiravir and one called nirmatrelvir, and both of these are available through the FDA emergency use authorization. As mentioned, there are also 3 monoclonal antibodies, either in combination or singly, that have been demonstrated to decrease disease progression in those high-risk patients. 2 of the combinations of monoclonal antibodies have been found not to be active against Omicron, which, as you've heard, is by far the dominant species in the United States. And just in the last week, the FDA emergency use authorization programs have been put on pause. So these monoclonal antibodies no longer available. However, a 3rd one called sotrovimab retains activity against the Omicron variant and is available by FDA emergency use authorization. Well, how do we know what to do? How do we know what strategies work? And sometimes what we do is turn to guidelines. I'm really proud to be one of the 3 co-chairs of the NIH COVID-19 Treatment Guidelines panel. This panel was formed in April of 2020, soon after the first cases of COVID here in the United States, with the goal of assembling a group of about 50 people from the government and from academic institutions across the country. And our mission is to look at all available data, synthesize it, and then make practical treatment recommendations to practicing physicians and the general public in the United States. We know now that we also have a large audience of people internationally. So what do the guidelines say about COVID-19 treatment in 2022? Well, first, let's look at inpatients. And you can see the last time we updated the guidelines was just last month. In fact, we've updated the guidelines 40 times since we first began in April of 2020. So for inpatients admitted for COVID-19, and I underlined the word for because there are patients who are admitted today with COVID-19, meaning that they're admitted for another reason, but are found on routine testing to actually be infected with the virus. And so for the group admitted for COVID-19, the least sick group are those who are hospitalized, but not requiring oxygen. And the guidelines say for those who are at high risk of disease progression, again, elderly or with co-diseases, the recommendation is the antiviral remdesivir. In this early stage of disease, no immunomodulators are recommended. The more commonly admitted patient is hospitalized because they require oxygen. And the guidelines say if it's a minimal oxygen requirement, same strategy, use the antiviral remdesivir. However, more commonly, for a significant oxygen requirement, use a combination of the antiviral remdesivir with the immunomodulator, the corticosteroid, a powerful anti-inflammatory, dexamethasone. And then for the sickest in this group, people who need oxygen and have rapidly increasing oxygen needs and have demonstrated significant inflammation, add a second immunomodulator, either baricitinib or tocilizumab. And we know that these three immunomodulators have been associated with mortality benefits. And finally, the sickest group are those who are hospitalized and require high flow oxygen or even being put on a respirator. And here the guidelines say really focus on the immunomodulator, dexamethasone, and within the first 24 hours of being admitted to an intensive care unit, add a second immunomodulator, in most cases, tocilizumab. Well, have these made a difference? Have these interventions made a difference? Here's some data from a group called the Premier Health Database. They looked at hospitalized patients in the United States in the second half of 2020 who had COVID-19. A large number of patients, over 190,000, cared for at over 800 US hospitals. Who were these patients? Older, the average age was 64, about half men, half women, good representations from Blacks, 19%. 2/3 had either Medicare for seniors or Medicaid for economically disadvantaged people. And over 20% had other significant illnesses like chronic lung disease, obesity, or high blood pressure. Well, what did we notice in this big cohort of US patients hospitalized with COVID? Well, the treatment trends were notable. So dexamethasone, that immunomodulator use, as shown in the graph in blue, went from 7% use all the way up to 77% use when clinical trials showed benefit and guidelines recommended its use. Remdesivir, the antiviral, went from 5%, shown in red, up to 47% use. And in yellow, we see anticoagulants or blood thinners, which is an emergent therapy, at about 25 to 30%. So you can see the clinical trials really made a difference here. Demonstration of clinical benefits led to endorsement by guidelines and very rapid uptake by the medical community. Well, did it make a difference for patients? Well, the first thing to say is that the length of stay was reduced over this time period. Both hospital stays and intensive care unit ICU stays were reduced by a day. Well, that's impressive when you think of the hundred or the tens of thousands of people involved, but even more significant was mortality. So over this time period, mortality with the improved use of these proven interventions was reduced by 35%. And that has continued to reduce across the country and across the world. Well, let's turn to outpatients. And again, we just updated our guidelines on December 30th. And here's what we say. For high-risk outpatients, again, on the basis of their age or co-diseases, with mild to moderate COVID, we recommend 4 therapies, and they're going to be listed here in order of preference. Number 1 is the new antiviral protease inhibitor known as nirmatrelvir. This is an oral drug which is given for 5 days, and clinical trials showed that it decreases clinical progression by 89%. What are the issues with this drug? It needs to be given with a second drug called ritonavir, which can cause drug-drug interactions with other important medications that people take. An even bigger issue is that it is in limited supply in the United States right now. Number 2 choice is the monoclonal antibody sotrovimab that requires only a single intravenous infusion, and in clinical studies showed decrease in clinical progression by 85%. What are the issues? Well, it's an IV infusion, so the logistics of receiving it can be challenging, and once again, a limited supply. Number 3 is remdesivir, the antiviral polymerase inhibitor. And we use for outpatients a shorter course of therapy, a daily IV infusion, but 3 days in a row. And that scheme led to a decrease in clinical progression of about 87%. And as you can see, these three therapies roughly the same in terms of reducing clinical progression. But you can imagine a daily IV therapy for 3 days also poses logistical issues. Only when the three cannot be used is the fourth choice, and that's the antiviral molnupiravir. This is a polymerase inhibitor that actually works against the virus by inducing mutations in the virus. It's given orally for 5 days and is less effective than the three therapies above. It decreased clinical progression on clinical trials by 30%. And you can imagine a drug that, or a compound that induces mutations, you would have issues giving it to pregnant or breastfeeding women or children. I want to highlight two other issues with our current outpatient medications. The first is, as I've already suggested, some of these are in quite short supply. And what do we do when we have medications that can benefit high-risk patients, but we don't have enough of them? We're put in an uncomfortable position where we have to prioritize patients for the medications. So the guidelines have actually taken a step in this and considered which patients should be the highest priority to receive these medications which are in limited supply. And the basic thought here is the patients most in need should have the highest priority. So tier 1 in our guidelines says that the group that should receive these first are immunocompromised individuals, people who immune systems are not functioning completely well, either because of another disease like cancer or an organ transplant, or because they're on medications which decrease immune function. And that's regardless of their vaccination status. As you know, many immunocompromised individuals will not develop a suitable response to vaccines. Then the second group are unvaccinated individuals who are either elderly over the age of 75 or are over the age of 65 if they have additional risk factors. And again, that would be a series of other diseases that they have that increase their risks. This is the group that's prioritized across the country in terms of who should receive the outpatient therapies. You can see the other tiers here take into account vaccination status, age, and whether you have other concomitant diseases. And just to put it on the line, it's uncomfortable for us as US physicians to have to prioritize among our patients for therapies which we know work. So this is putting many providers in an uncomfortable situation. And then my last point is just to point out that distribution of these drugs is not equal among all Americans. So these are data on COVID patients, and they looked at over 800,000 of them across 41 healthcare systems in the United States, and looked and saw how many people got monoclonal antibody treatment, one of the treatments I've highlighted during this presentation. The first answer is it's less than 7% of all patients receive these therapies. But even more striking is when you look by race, you can see that white patients proportionally received monoclonal antibody treatment more than other groups, more than Blacks, more than Asians, and more than other races. So there is a racial disparity here. Similarly, ethnicity, non-Hispanics receive these therapies more frequently than Hispanics who had COVID disease. So there is a racial and ethnic disparity in who is receiving COVID-19 treatment here in this country right now. And that is a problem we need to address. Lastly, I'll just thank some colleagues for slides. And although I focused on treatment, I want to echo Dr. Corey that vaccination is an important tool against this epidemic. This is my division of infectious diseases. And yes, that's me up here rolling up my sleeve. So I'll stop there. Again, thank you for inviting me.
Thank you, Dr. Gulick. That was so clear and helpful. And a huge thank you to IDSA for all the work that you guys have been doing in synthesizing this information so quickly for frontline physicians and other healthcare providers across the country. So last, but certainly not least, Dr. Georges Benjamin, who I think needs no introduction. He's known as one of the nation's most influential physician leaders because he speaks passionately and eloquently about the health issues having the most impact on our nation today, including, of course, COVID-19. From his firsthand experience as a physician, and I will say he served for a while as a chief of emergency medicine, so I count him as an emergency medicine colleague. He knows what happens when preventative care is not available and when the healthy choice is not the easy choice. He's been executive director of APHA since 2002 and continues to lead the association in its amazing push to make America the healthiest nation in one generation. Dr. Benjamin is, among many other accolades, a member of the National Academy of Medicine and the National Academies of Science, Engineering, and Medicine, and also serves on the board of numerous organizations. He's been named one of the top 25 minority executives in healthcare by Modern Healthcare magazine 3 times, in addition to having been voted among the 100 most influential people in healthcare for a decade straight. Dr. Benjamin, it is my pleasure to introduce you and to turn this presentation over to you.
Thank you, Dr. Rainey. If we go to that next slide, let me just say that you know, when public health folks, I'm going to pick up on the guidance discussion. When public health folks make guidance, like CDC, they make that guidance decisions based on science as we understand that science at that particular point in time. And that's important for people to understand. You just heard a very eloquent presentation about our treatment guidance, which we know has gone from, quite frankly, just providing supportive care to now a range of therapeutic options for patients. Public health has had to do exactly the same thing. We also have to communicate that science and the uncertainty around it, particularly when we have a challenge like this. So you have an infectious diseases that is with a high degree of variability and change, lots of variants, lots of understanding of what the virus actually does, based on a lot of assumptions that turned out in some cases not to be true, such as we thought this would be like SARS 1, but it turns out it's its own creature. And we have to cover several audiences with different levels of understanding and people with different desires to use the information for different purposes. What I mean by that is policymakers have a reason for the information, which is different from journalists, which is different from, you know, the average person on the street, which is different from the clinicians who have to implement that. So we're going to talk a little bit about some of the recent guidance that CDC did, masks, the one on isolation and quarantine, testing in terms of return to work, and this issue around the definition of fully vaccinated.
Oop, Dr. Benjamin, you muted you by accident. Apologies. I'm not sure
problem.
how. There you go.
So the mask issue, I want to make it clear. This has always been the approach to masks. We recognize that the purpose of masks is as a risk reduction tool. In addition to the other things, before we had vaccines, masks were extraordinarily important, but they are also still extraordinarily important. And we now know because of Omicron's significance in terms of its infectivity, masks still play a very important role. So obviously not having a mask as a barrier in front of your face means you're not providing any protection at all. Cloth masks do provide protection, but they need to be multi-layered. They're certainly better than no mask at all. And they're probably a little less protective than surgical masks. The benefit, of course, is that you can wash and clean your surgical mask. I mean, your cloth mask, but your surgical mask essentially is, for all practical purposes, really a one-time mask, and you should throw it away. But the gold standard, of course, here are the high filtration masks, N95, KN95. I want to point out, though, that a high filtration mask that is not properly worn and tight is certainly not giving you the protection that you need. So you have to wear those masks, as well as the surgical mask or the cloth mask, properly to get the best seal that you possibly can for this disease. Next slide. So as we know, very recently, CDC, using some new information, updated and shortened the recommended isolation and quarantine period for the general population. They also made some recommendations for long-term care and clinicians in healthcare settings, acute healthcare settings as well. But I think this quote, which actually is that Dr. Walensky said, really gives you a sense of what they were trying to achieve. They recognized that Omicron was spreading. They also recognized that they needed to give guidance that people could actually use in a functional way. They pointed out that prevention is our best option. Getting vaccinated, and still using this at this point, the term boosted, wearing a mask, in particularly outdoor settings and areas of substantial and high community transmission. And of course, take a test before you gather, particularly when you're around people you don't know. This advice has been persistent and consistent. And I just want to encourage people to continue to follow this advice, because I think it's really sound public health advice. Next slide. Having said that, the way to think about the guidance is 10 days. Everyone should focus on the number 10 days. And they basically looked at some data, which I'll show you in a minute, which basically said that the greatest risk for you sharing your infection with others is the first 5 days. But that beyond that, there is still some risk, although it greatly diminishes after the 5-day period. And for that reason, you should certainly wear a mask. And these are for people who have obviously turned up positive and people who we have found are infected. So, you know, it can get really complicated if you think about too many different factors, but for the vast majority of people, we should think 10 days. And that's for isolation. And in quarantine, quite frankly, there's a variance on that. But at the end of the day, if you're going to quarantine, it's still 5 days, and then the next 5 days you should wear a mask. If you're boosted, if you're fully vaccinated and boosted, which the term I guess we're now using is up to date, then you can not have to wear that mask after 5 days. But from a practical perspective, you should be wearing a mask anyway. So wear the mask, and if you're infected, obviously for 10 days, that's the period of time you ought to be thinking about it for most people as we think about the new guidance that they put out. Next slide. And to give you a sense of this, if you look at this graph, it just shows you that most people are not shedding virus after about 5 days. And this is for one preprint study, but there have been many other studies that they looked at when they made that decision. And again, as they pointed out, regardless of the duration of the incubation period, almost no transmission was predicted beyond the 5 days from the time you had symptoms. Next slide. I think the other thing that's interesting, of course, is that viral clearance with vaccination is enhanced. And again, this is a strong argument to get vaccinated, a strong argument that if you're vaccinated, you're less risk to others by viral shedding. Next slide. And then the big debate about antigen tests for return to work. And of course, as you know, we really have two tests that are out there that we're using with some regularity. One, of course, is the PCR test. The challenge that using it for predictivity to go back to work is that it's quite often positive both before and after you are contagious. So it really isn't the best tool to use. If you're negative, great, but far too many people are still positive, and not just a few days afterwards, sometimes weeks afterwards, and we still have people that even positive months afterwards. But if you use the antigen test, you're much more likely to for that to be reliable as return to work. And if you combine that with the loss of symptoms, meaning that you're feeling better, you've lost all your symptoms, again, from a risk-based perspective, your risk of infecting others is greatly reduced. This is an important thought process for people that are in the healthcare setting, because while we would prefer everybody to be totally, asymptomatic and totally symptom-free before they go back to work, the best tool to think about that, it makes in terms from a risk perspective, is to make sure that you get a test. And if you're negative and you're symptom-free, you're much more likely to be able to go back to work. And again, that 10-day period is very, very important as part of that process for guidance for people who are having to make these kinds of decisions. Next slide. So obviously we don't want people to go to work if they're not feeling well. That just makes a lot of sense. We don't want people at work because they're not going to be as productive at work. We know that these symptoms from Omicron are often very mild, but very mild does not mean that it does not have significant morbidity and significant mortality, both for vaccinated people and, which is very rare, but for some vaccinated people, but certainly for unvaccinated people. Again, and most transmission occurs early, as we saw in those charts. Next slide. So finally, CDC has been under some pressure to decide what fully vaccinated means. And I personally think that they've picked a reasonable term that does not create confusion as we go forward. The concept of being up to date means that you've received all the recommended vaccines, including recommended boosters when you're eligible. And I think it's a more rational way for us to think about being vaccinated, because this allows us to look forward in terms of whether or not someone needs to be vaccinated in the future. It also allows us to customize this from a clinical perspective for those people who are particularly immune compromised and may need a fourth vaccination, and maybe an additional one later as we get a better understanding of the durability of vaccinations in immunocompromised individuals. Next slide. So, as people think about this in summary, we like to make this guidance based on the best biological science and evidence at the time, realizing that that will change over time. But we also have to utilize the best behavioral science to achieve compliance. So when a public health agency is saying, well, this is the best science that we understand, but we want you to do X over Y because we think that's the best way to get people to do what we want them to do. That is taking both the biological science and the behavioral science and optimizing the guidance and the advice in order to actually achieve the public health goal that they're trying to achieve. And that recognizes that you have to communicate this in a way that addresses the degree of uncertainty to ensure and maintain trust. The challenge we've had is when we've come out and said things that sound like they're certain, like we did, quite frankly, when we said, if you are vaccinated, you won't have to wear a mask, and then had to reverse ourselves, that creates some real challenges. And so we just have to be a little more thoughtful as we communicate what we know when we know it. And I think that's my last slide. Thank you very much.
Thank you, Dr. Benjamin. Well said. I mean, this is as much a issue as is true with so much of public health. It's as much a biological issue as it is a psychological and behavioral and structural issue. So thank you for that. I'm going to invite all of our speakers to turn their cameras on and turn their microphones on. I think we could probably go for another hour with the questions that have been put into the Q&A. A huge thank you to all of you who are attending, who've put such thoughtful questions in. We, of course, are not going to have time to get to all of them. So I'm going to try to direct a couple of quick questions at the various speakers, and then I have a final question for the whole panel to weigh in on. So my first question for Dr. Nuzo is, during the current phase of the pandemic, is surveillance testing still a useful strategy? Can you talk about kind of how those case numbers are changing and about the concept of surveillance testing as we deal with Omicron and home tests?
Yes, I mean, I think we will get to a point one day where we stop looking at cases in the way that we're looking at them now. But I think it is still helpful for us to understand how the virus is changing, whether there are new variants emerging, whether people are getting reinfected in ways that we don't expect. So I still very much look at cases, and I think testing to try to understand this virus is still important, and also to try to get a picture of how much illness it's causing. I mean, many of the questions that we wrestle with, how severe is it? How transmissible is it? All of those things are hinge on having good denominators. And surveillance testing is one of the ways that we get the good denominators that we can help sort of couch the concerning numerators against. So I still think it's important. Obviously, we have to interpret all the data differently as we learn more. And when we're talking about testing in a highly vaccinated population, how we interpret those data is going to change than when we were talking about testing in a completely unvaccinated population. But I think with all those caveats and putting all the data together, hopefully we can continue to triangulate our way to the truth.
Isn't that always the way? It's the triangulation to the truth. That's science. Dr. Corey, for you, a lot of kind of really impressive thank yous for that drive, for that extraordinary collaboration. Folks had questions about the discussions that they've heard about a universal coronavirus vaccine, and would love to hear your thoughts on that.
Well, my thoughts are that'd be great. And there is work on it. There are, there's a monoclonal that sotrovimab that is in a conserved area. So conceptually, there are some nice ideas coming out there. It's a little bit harder to both manufacture and work on it, but I do think that we will see some clinical trials of what we'll call a pan-sarbecovirus, which is sort of pan or across SARS-CoV-1, SARS-CoV-2 kind of vaccines that will emerge in the next 6 to 9 months, and we'll see where human testing brings them. I mean, having said that, ancestral strain is impressive. We have put into clinical trials both beta and delta variants and used RNA for that. They really weren't impressively different than ancestral strain. In other words, they were really not really quite as good. So we will be looking at strain variation and platform variation to see if we can increase the durability and frankly, increase the magnitude of the neutralizing antibodies response. So these cross neutralizations will still give us high titers.
We should be so lucky. And of course, we'll be watching in the months to come to see what happens with the durability of the current. I know there were a bunch of questions in there about, are we going to have more boosters coming? I think the answer is we're going to wait and see for now. Thank you. Dr. Gulick, a question for you. There were a bunch of folks who wanted to learn a little more about Paxlovid, of course, which has been hailed as this miracle cure to COVID. We know that there are, you outlined some of the kind of ways that we're triaging who gets it first, but people were curious to know a little bit more about contraindications and kind of the age limits around Paxlovid prescriptions at this point.
Sure. The first thing to say is that miracle cure would be an overcall here. What it did show was a decreased risk in clinical progression for people who were at high risk but had mild to moderate COVID and were outpatients. That was the group that it was studied. Two important caveats about those data, even though it was an 89% reduction. One was they were all unvaccinated. That was one of the requirements for the study. And the second is this was pre-Omicron. So that was likely in the era of Delta that we saw these effects. Nevertheless, it's encouraging that we have an oral antiviral which could actually impact COVID-19 for outpatients. The thorny part of this drug is that it requires that second drug called ritonavir, which is a booster. It boosts the levels of nirmatrelvir, which is the protease inhibitor itself. And the boosting is done by interacting with the liver, and that can cause drug-drug interactions with many other drugs. So people need to be quite careful about that. Why are the restrictions in place? Well, the supply was very limited at the beginning. It is scheduled to increase, and the US government has bought many more doses of this drug that are expected in the next couple of months. So we may see increasing supplies. But as I tried to emphasize, when you have limited supply, really you need to focus on the people that will benefit the most. That is the people who are at the greatest risk. And we know either being immunocompromised, not having an intact immune system, or being elderly are the two biggest risk factors for progression of disease. And that's where those prioritization schemes come from.
Thank you, Dr. Gulick. And I will add for those who are prescribers in the audience that severe renal disease is also a contraindication. And I will say, personally, as an ER doc, I have only prescribed Paxlovid for one person so far, because everyone else that I wanted to prescribe it for had contraindications, medications they were on that they couldn't come off of, or had, unfortunately, renal disease, although my ID colleagues probably have had a lot more luck than I have in getting it prescribed. There are also some great websites that provide access to both monoclonals and the new oral antivirals that HHS has created. If you Google HHS antivirals access, you can find their real-time maps of access at pharmacies around you. Dr. Benjamin, a question for you, and then I will have a final question if we have time for the panel, is to talk a little bit about the need for research aimed at improvement of public health education, and how you would like to see the people attending this webinar today think about combating the distrust of the public health establishment, science, vaccines. If you could give people a couple of takeaways to bring back to their communities, what would they be?
Yeah, I think the first thing is to recognize that we need to depoliticize this debate. And, healthcare and public health community are doing this based on the need to try to protect people's health and well-being. And so we all need to take a deep breath and step back and recognize that people that are giving you the wrong information are doing it for a range of nefarious purposes. And I always used to tell my patients, look, here's my best advice, but here's where you can go for a second opinion. And so I encourage people to go to authoritative sources, like the National Academy of Medicine, like an academic health center, like the CDC, like in most cases, Infectious Disease Society of America, another authoritative place to go. But go to authoritative sources. And while Facebook and other social media tools may deliver authoritative information, always go to the source. Go to the original source.
That is a great recommendation, I think, for all of us, and all of us that are teachers, hopefully tell our students that as well. So thank you, Dr. Benjamin. So the final question, and I'm actually going to ask you each to just give me a sentence or two, because I do know that we're coming right up against the top of our 90 minutes. We've seen a lot of calls in the last couple of weeks to talk about this as now being in an endemic phase, or that this is the new normal, that it's time for us to move past our COVID precautions. And I would love to hear from each of you kind of what your response would be if you had a friend or family member ask you about whether or not we're currently in the endemic phase, and how that changes what's next. I'm going to go actually in reverse order of how you spoke. So I'll start with Dr. Benjamin, Dr. Gulick, Dr. Corey, and then Dr. Nuzo.
Look, all pandemics end, but this one is not there yet. And I think it's important for people to follow the current advice that we have. Get vaccinated, wash your hands, wear a mask, keep your distance, and it will come. The great pandemic in 1918 went 3 years too. So our species has seen this kind of problem before. It will end. Just be patient.
Thank you. Dr. Gulick.
Well, I'll say that whenever we've tried to make predictions about COVID-19, we've often been wrong, and this virus continues to surprise us. So I'm an optimist. I think right now enough people have either had Omicron infection and or been vaccinated that there may be enough immunity to drive this infection to low levels. That's the hope. And could we actually continue there at low levels for a while? The pessimist in the crowd would say yes, but what about the next variant that is already brewing somewhere and may come along? And only time will tell as to which scenario we're going to see.
Thank you. May our crystal ball foresee the good side exclusively. Dr. Corey.
Well, endemic is not over 500,000 cases a day, I mean. So I think we will get to endemicity, and part of that will be perception. And some of that will be when we not only have essentially baseline immunity that's in the 90s from either prior infection and vaccination, but we also perceive that we will have drugs if you get breakthrough infection that will not alter or make you sick and have the higher incidence rate. And so I think we do have the tools to sort of change our perception. I would call endemicity eventually to happen. We will have variants, but we will have to learn to live with this pathogen. And I think our science, our remarkable science, will allow us to live back to the way we did before. At what level of case count? I don't know. And I hope that we're able to keep the mortality less than what we have for influenza.
Thank you. Isn't that the debate right now? Saying that we're going to do that our goal is H1N1 levels is not, to me, a reassuring future. Dr. Nuzo, your thoughts?
Yeah, I agree with the statement that all pandemics end, but this virus isn't going away. It's not going to disappear. And while we are going to, at some point, end mandatory measures, that doesn't mean that we can't and shouldn't continue to take measures to protect ourselves individually and voluntarily elect to try to protect ourselves. And the thing that I really stress to people, because I know lots of folks who are worried about the virus, but not yet vaccinated, is that all of us are probably going to meet this virus at some point, and really the vaccines, offer us the armor, the best defense, when we have that first contact with the virus. And so I think for people who are hoping they can just ride out this wave, to just let people know that, COVID is in our future, and we want to go into that fight with the best level of protection possible.
Thank you. Well, a huge thank you to all four of you for this terrific hour and a half of presentations. A thank you to the APHA staff and to the National Academy of Medicine for organizing the webinar. But most of all, a thank you to all of you who've attended. As both a physician and a public health professional, I know how tough the last 2 years have been. As a parent and a child of elderly parents, I know how tough the year has been. The past couple of years have been personally as well. And I want to thank all of you for continuing to show up day after day and continuing to do this work. We wouldn't be in as good of a place as we are today if it weren't for all of you. And you're taking the time to learn and to engage in webinars like this helps to move us more quickly towards a better future. So I just hope that you all, as attendees, can also give yourselves a thank you for everything that you're doing and have done. With that, I will close up. I do want to remind folks that everyone who registered for today's webinar will receive an invitation to the next webinar. Today's webinar has been recorded. I've seen lots of questions about that. The recording, a transcript, and the slide presentations will all be available on COVID19conversations.org. And of course, if you have any ideas or suggestions for webinar topics, please email apha@apha.org. Thank you again to our panelists, to the National Academy of Medicine and APHA for co-sponsoring this webinar series. And please stay healthy and safe. Thank you all.